Start. Good morning, and welcome to the 43rd Annual MSK Alumni Meeting. We had a very productive conference yesterday. I think I see that most of you attended yesterday's conference as well. We had over 20 speakers covering scientific and clinical topics in esophagogastric cancer, folks coming from all over the country to honor this man, and international speakers as well. So it was a great day yesterday. And as a program chair now, it's my pleasure and honor to welcome Dr. David Ilson and introduce his Grand Rounds presentation. As you all know, Dr. Ilson has been at MSK for many, many years. Next year will be his 30th year serving the mission of MSK. He completed his MD and PhD and medical training at NYU and began his medical oncology fellowship at MSK in 1989. Over these 30 years, he served on numerous trials and really helped develop drugs such as Irinotecan and Paclitaxel for the upper GI malignancies. He's a medical oncologist and attending on the GI oncology service at MSKCC, has authored numerous publications. I counted over 150. At some point, I just lost count. So a really amazing, productive career that just keeps going. The title of David's talk this morning is Esophago-Gastric Cancer, 30 Years, Single Institution Experience. Please.
Well, thanks very much, Yelena. Having been at one institution for a long time, and you sort of step back and look at the perspective, and so one of the strengths of this institution is that because you can focus so specifically on a disease type and a research area, that you get insights into the disease and the natural history of cancer that just is not possible anywhere else. And it really has been a tremendous experience, and I'm very grateful to the institution. So these are my disclosures. These are mostly consultancies and advisory boards, and these are trials that I've been involved with recently with pharma. So what I'm going to cover in the talk today just is, again, it's sort of the arc of drug development in upper GI cancers that we really played a critical role. And I think MSK and our group was instrumental in the development of Paclitaxel and Irinotecan in upper GI malignancies. We also had a very significant voice in the evolution of neoadjuvant and adjuvant treatment in this disease, as well as the evaluation of novel agents and combined modality therapy. I think we helped to establish the potential use of PET scan assessment for response to therapy. And I think one of the contributions that I've made is to sort of really try to help develop a global consensus about adjuvant therapies in the U.S. And some battles fought on the NCCN guideline committees, and I'll comment about it pays to be a global citizen when you try and put the treatment of diseases in perspective. And then at the end, we'll talk a little bit about targeted agents and immune checkpoint inhibitors, which is really the next wave of drug development. So, I mean, collectively, esophageal and gastric cancers are not uncommon in the United States. We see a little more than 43,000 cases this year. It's about 3% of all U.S. cancers. Gastric cancer still is more common and accounts for about 60%. Esophageal cancer, the more virulent disease, about 40%. And we continue to see a decline in more of the more distal gastric cancers, probably due to Helicobacter pylori eradication, and a shift in the epidemiology to cancers of the esophagus, GE junction, and cardia, which are much more aggressive, virulent diseases. And survival has improved over the last several decades. You can see in the 70s, esophageal cancer was like pancreatic cancer. It was a 5% survival. Gastric cancer also pretty poor. But we are seeing modest advances, I think, with improvement in surgical staging and techniques, as well as the incorporation of effective adjuvant treatments. So looking at how esophageal and gastric cancers stack up in the U.S., you can see that neither disease cracks the top 10 in either men or women, but esophageal cancer, again, because it's so virulent, is the 7th leading cause of cancer death in men in the United States. Globally, this is a huge health problem. If we look at men and women, gastric cancer is the 5th in incidence, esophagus cancer the 7th in incidence. But if we look collectively at the mortality from these diseases, it's actually the 2nd leading cause of cancer-related death after lung cancer. So this is a huge global health problem. Where do we see this geographically? This is a disease largely of Eastern Asia, but also for unclear reasons, Eastern Europe and South America, particularly gastric cancer, much more common. You can see in North America, this is a relatively less common disease. So when I started practicing 30 years ago, we had a rather horrific cocktail of, I guess I see Dr. Kantoff and it makes me think of MVAC, but we had infusional 5-FU and cisplatin. And this was a regimen that bordered on barbarism. We actually admitted to patients to the hospital for 5 days, and they received a 4 to 5 day infusion of high-dose 5-FU with 100 milligram per meter squared of cisplatin. And that was the standard of care at that time. And I could see early on, subjecting patients to this, that this had substantial toxicities. Patients would be hospitalized 30 or 40% of the time for complications, really severe GI, hematologic, renal complications. And it really was a marginally active treatment. Only a 20% response rate. Patients lived an average of only 8 to 9 months. So believe it or not, we actually then tried to intensify this regimen, and we'll talk about the Memorial experience, adding a taxane to conventional platinum 5-FU and the DCF regimen. FLOT, which is the German regimen, better tolerated. It uses FOLFOX with Docetaxel, but it doesn't buy you a lot. It's a 10% improvement in response rate. Arguably, this has even less tolerable toxicity than this stuff, and you get a 1 to 2 month improvement in survival. I'm not going to talk about this, but we've now really shifted to using colorectal cancer scheduling for chemotherapy, a lot better tolerated. Just changing the way you give 5-FU using oxaliplatin, you eliminate probably 80% of the severe toxicities. But we didn't know this back in 1989. So I'm not going to go through all the studies individually, but this was our development of Paclitaxel in the 1990s. We were really, again, looking for alternatives to high-dose cisplatin and infusional 5-FU. And in collaboration with Jaffer Ajani at MD Anderson, we did the seminal phase 2 trial when we got Paclitaxel from the NCI, and 250 milligram per meter squared, 24-hour infusion. We used to hospitalize patients for this, and then they would get GCSF. This was a large phase 2. And this was one of the first new drugs that we identified in the 90s to have single-agent activity, a 32% response rate, duration of response about 4 months, and a survival a little bit more than a year. And again, a testament to the beauty of being at a single institution and the fact that I put every single patient on this trial myself. We actually had a durable, complete response to Paclitaxel, to this. This was the only patient that we actually followed the protocol, and we were supposed to give 6 more doses after the complete response. And this patient actually had a squamous cancer with liver metastasis, anastomotic recurrence, and he actually had a durable, complete remission, and he died of old age 20 years later at age 82. Then another influential study that we did was weekly Paclitaxel. We did one of the first phase 2 trials of weekly Paclitaxel, really based on the breast cancer experience, and a modest response rate, 16%, but a duration of about 6 months, overall survival of 9 months. So clear that single-agent Paclitaxel had activity, and this publication had a lot of impact in Asia because now, in conjunction with other papers, weekly Paclitaxel became the standard salvage regimen for gastric cancer in Asia. I'll talk later about the development of Paclitaxel and radiation, but I just want to pause for a minute because I talked about the old cocktail of infusional 5-FU cisplatin, which was quite horrendous. So we actually tried to add Paclitaxel on top of this regimen. And in another collaboration with the MD Anderson group, we combined Paclitaxel 3-hour infusion, this 5-day 5-FU infusion with 100 per meter of cisplatin, 60 patients with esophageal and GE junction cancers, and we saw an impressive response rate, 48%, duration of 6 months, survival of 11 months. But this was not for the weak of heart. 48% of patients were hospitalized for toxicity. And my take on this when we submitted this to the JCO is that really the optimal dose and schedule of these drugs remain to be established. That being said, however, Dr. Ajani thought this was the greatest thing since sliced bread. So he approached Sanofi Aventis, and they decided to add Docetaxel to 5-FU platinum. And again, this is a daunting regimen, a 5-day infusion of Cisplatin, 5-FU. They diminished the platinum dose to 75 per meter, and they added essentially full dose weekly, every 3 week Docetaxel. And this was a randomized trial of conventional 5-FU cisplatin with or without Docetaxel. And again, I've told you that if this is a control arm, anything is going to look better. So on this large phase 3 trial, these were young patients. Median age was 55, good performance status, and there was a response rate advantage of about 12% and a 2-month improvement in time to progression and a little bit of an improvement in median overall survival. But not surprisingly, the toxicity was quite horrendous. 82% rates of neutropenia, and 50% of patients were taken off this treatment due to adverse events, or they just said, I can't take it anymore. So quite a toxic regimen, but this trial did lead to regulatory approval for Docetaxel as a triplet regimen in gastric cancer. So what was my take on this? Well, I actually wrote an editorial for the JCO about the DCF regimen in gastric cancer. And the title was, Does the Punishment Fit the Crime? I was actually inspired by Gilbert and Sullivan, where people get boiled in oil for kissing in public, but it's Does the Punishment Fit the Crime with DCF? So this was a study of the quality of life data from TAX 325, and they kind of set the bar pretty low here. You could have if your deterioration, not improvement, if your deterioration in quality of life was slowed with DCF by 5%, that was declared victory. So this curve looks really impressive, right? I mean, so the decline of your quality of life by 5% was better with DCF. But then if you read the toxicity and the hospitalization rates and the fact that 50% of patients were taken off for toxicity. So the point I made in this editorial was what toxicity is acceptable for what magnitude of benefit. And these were young, good performance status patients, and shockingly, oncologists in the community were giving this to 70-year-old ladies that would come into their office with metastatic gastric cancer. So the Germans came up with a more tolerable triplet regimen, FLOT. FLOT is a modified FOLFOX. FOLFOX is far better tolerated than infusional 5-FU platinum, and they added Docetaxel to this regimen. But importantly, most of our patients, remember the TAX 325, the median age was 55. In reality, most of our patients with metastatic gastric cancer are in their 60s or 70s. So does triplet therapy benefit patients that are the most common presenters with this disease? And actually, Dr. Albetron, who was at our conference yesterday, this is a very important randomized trial conducted in Germany. They compared the FLOT regimen in 143 patients with a median age of 70, and this was a modified FOLFOX over 24 hours with or without the addition of Docetaxel every 2 weeks. And not surprisingly, the response rate was better with Docetaxel, but the other endpoints were not better in an older population. No significant difference in progression-free or overall survival. FLOT was not better for older patients, and the toxicity was far greater. 82% rate of grade 3-4 adverse events versus 40% for FOLFOX. And here you can see graphically, PFS, no difference, overall survival difference. Maybe patients that had locally advanced disease had better progression-free survival. But this really made the argument that triplet regimens should not be used in older patients. And then lastly, This, another important study from ASCO just a few months ago, this got actually buried in the poster discussion session, I don't know why, but this was a 700-patient study from Japan. Japanese oncologists do not like to hurt patients. They err on the side of being less toxic with their treatments. And S1 cisplatin is a standard regimen, and they repeated the docetaxel question. They randomized patients to S1 cisplatin with or without docetaxel in metastatic gastric cancer. And guess what? There's no difference in survival. So an S1 platinum is probably a much better control arm than 5-FU platinum. So they saw no difference in overall survival in this 700-patient randomized trial. And was there any difference by histology, intestinal versus diffuse? There was no difference. So I think patients that are older, triplet regimens shouldn't be used. 5-FU platinum, FOLFOX really should be the standard to treat metastatic disease. And this is an argument I was making since I wrote my editorial over 10 years ago. So the other drug that we developed at Memorial, and this was really initially spearheaded by Len Saltz, who actually, I remember Len didn't used to spin down the pharmacokinetic tubes yourself with the centrifuge when the PK values were being drawn. But Len was really instrumental in developing irinotecan in GI cancers. But he also did a very innovative phase 1 combination of irinotecan and low-dose cisplatin, because we were really sort of wedded to this very high-dose cisplatin. You give this huge dose in one day. So we fractionated the cisplatin and gave low-dose irinotecan. And again, the beauty of a single institution, you treat and see all the patients. And I had a patient on this trial that had a dramatic response with esophageal cancer, and he actually had retinal metastasis that responded to this regimen. And this cocktail, you didn't see diarrhea, you didn't see mucositis, neutropenia was the main side effect. So then we convinced Pharmacia to fund a series of trials looking at this combination. And we conducted a phase 2 trial in 35 patients with adeno and squamous cancers, and we saw a very high response rate, 57%, typical duration, the survival a little bit more than a year. And it was well tolerated. Again, I treated nearly every patient on this trial, so I knew we were onto something, that this was better tolerated. We avoided the toxicities of infusional 5-FU and high-dose platinum. And the other thing that we captured in this trial was patients' dysphagia got better. They were eating better. And I'll show you a scan in a minute, a patient I'll remember very vividly that we treated. So then we pursued phase 1 combinations of this regimen with Paclitaxel and bolus 5-FU. We did not want to use infusional 5-FU, but the only thing I'll comment on one of the phase 1s is that the combination of 5-FU, irinotecan, and cisplatin, we actually saw a number of responses in pancreatic cancer. So we were anticipating the potential advent of FOLFIRINOX, which is now the standard of care in pancreatic cancer, but we clearly saw activity for synergy between irinotecan platinum and combination with a fluorinated pyrimidine. And we'll talk about the radiation studies that we pursued subsequently. So I'll never forget this patient. This was a young man that we treated on the trial that was basically barely able to tolerate his saliva and a huge, bulky esophageal mass. And this was 6 weeks into treatment. The patient came in saying, oh, I had steak on the barbecue, and he gained like 40 pounds back, and and he had very little toxicity from treatment, and it was an outpatient regimen. So we kind of put dysphagia on the map as an endpoint for metastatic disease trials. There were some earlier series, but you can see consistently in metastatic disease with chemotherapy, if you look for it, you get swallowing improvements with chemotherapy. And even in some of our even one of the ECF Cunningham trials, large randomized trials, 77% had improvement in dysphagia. And we learned from this experience that you don't always have to put feeding tubes in patients, you don't always have to put stents in patients, that we can try chemotherapy first and can lead to dramatic palliative improvements in quality of life. So we were very much wedded to this irinotecan cisplatin regimen, but if you really want to move it forward, you have to take it to a randomized trial. And unfortunately, The regimen really didn't hold up against FOLFOX and ECF. This was a randomized trial that we helped develop through CALGB and ECOG. It was a randomized phase 2 comparison of these available regimens in GE junction and esophageal adenocarcinomas. At that time, we also added cetuximab with the hope that this was going to be a platform to add other targeted agents. And if you look, response rate was the primary endpoint. So ECF and FOLFOX were actually pretty comparable. So the epirubicin here, maybe it doesn't add much to a doublet. Response rates were similar, progression-free survival was similar, and overall survival was similar. But alas, Irinotecan cisplatin, which I had devoted about 10 years to in drug development, was the sore third-place winner. So this regimen has now kind of been relegated to salvage. But you don't know something really works until you do a randomized trial. So I'm going to shift gears now and talk about multimodality therapy first in esophagus cancer, and then we'll talk about adjuvant therapy in gastric cancer and what has been our contribution to the dialogue. So what about chemotherapy alone for esophageal and G-junction cancers? We were actually a strong advocate of this approach back in the 80s and early 90s. Dave Kelson had done a number of phase 2 trials of giving chemotherapy before surgery. And certainly the smaller randomized trials, the MAGIC trial, which really set the bar for perioperative chemotherapy in gastric cancer, did treat some patients with GE junction tumors, and this was a positive trial for perioperative chemotherapy, and then a French trial, Platinum 5FU, a positive trial. The problem, however, is the larger randomized trials that focused purely on esophageal cancer were failures. And we'll spend a little bit talking about US Intergroup 113. This was Dave Kelson's trial. I think individually we put about 20 patients on this trial. I used to have a combined clinic with Manjit Bains, and we would see patients, and the standard arm at this time was surgery alone versus 5 cycles of our old nemesis, high-dose 5FU infusional 5FU and high-dose platinum with its really horrendous attendant toxicities. But we put 450 patients on this trial, adeno and squamous. There was absolutely no difference. It was a flatly negative trial, no improvement in survival, no improvement in the ability to operate on patients. So you didn't downstage patients, you didn't facilitate surgery, and the curative resection rates with preoperative chemotherapy alone were terrible. They were 60%. The British did a larger trial, 800 patients. They only gave 2 cycles of platinum 5FU, and they declared victory with this trial, even with a 6% improvement in overall survival, and really debatable. Was this really a positive trial or was it a negative trial? They were so inspired by this 6% improvement in overall survival that they took it to a 900-patient randomized trial comparing 2 cycles of platinum 5FU versus ECX. This is an important study in this 900 patients. It was a negative trial. I think it kind of killed off epirubicin. There was no benefit for adding epirubicin to 2 drugs. But also importantly and interestingly, more cycles of chemotherapy did not improve outcomes. So 4 treatments was not better than 2 treatments, and epirubicin did not add any benefit. So we learned from this trial, and it actually helped us take out epirubicin from the cocktail. But again, now this was a contemporary trial. So, okay, you know, this is the 80s and the 90s. So you get a 60% R0 resection rate. It's the 80s and the 90s. So now it's the 2000s. So everybody gets endoscopic ultrasound, PET scan, laparoscopy, and the R0 rates were still 60%. So I thought this was quite scandalous. And actually, the authors don't even mention how awful this curative resection rate is, and they make no mention of radiation therapy. Because you think if you can't operate on somebody, maybe you need to give them radiation. But no mention by Dr. Cunningham and colleagues. So they're cherished colleagues. So this is the Kelson trial. This really stopped the use of preoperative chemotherapy in the United States. This is absolutely a flatly negative trial. This has been updated a number of times. No survival difference with chemotherapy alone. And then, as I said earlier, curative resection rates of only about 60%. So that means you give this to patients and there's a 40% chance you can't even operate. And even in the patients that you operate on, there's a 30% chance of local recurrence. So these data scream that you have to give patients radiation therapy. So this is OEO2. This is that 800-patient trial from Britain. This inspired them to do a 900-patient trial. I don't know why, but the survival difference was 5%. So clearly, I think the data, even from years ago, argued that for G-junction esophageal cancers, there should be a role for radiation therapy. And that's really the standard practice in the United States, is concurrent radiation and chemotherapy, either by itself or followed by surgery. So the seminal study was conducted by the RTOG 8501. This paper came out when I started as an attending in the summer of 1992. And this was a randomized trial. At the time, the epidemiology was such that most patients we saw were still squamous cancers, but they put some adenocarcinomas on. And at the time, they were treated like head and neck cancers. They got radiation therapy alone. And this was a comparison of radiation therapy alone compared to a lower dose of radiation with or without infusional 5-FU and cisplatin. And again, this horrendous cocktail of 100 per meter squared of cisplatin with 5 days of 5-FU. And just imagine giving them radiation on top of it. This was a positive trial, however. This established that radiation, if you got radiation therapy alone, you didn't survive. I mean, there were no long-term survivors. But if you got chemotherapy and radiation, there was a tail on the curve of about 25%. So this established actually globally that chemotherapy and radiation was acceptable. And this really sparked the interest in using this regimen as a preoperative regimen. Now, the problem is that if you don't operate, you get local recurrence or persistence in about 45% of patients. So the argument is you really need to operate after this treatment is done. Now, we actually started using this regimen after this was published, and every patient wound up in the hospital. So this, from horrendous side effects. So with the development of Paclitaxel and Irinotecan, this really spurred us to look at new regimens to combine with radiation. So the first was Paclitaxel. Again, we were looking for alternatives to high-dose cisplatin and infusional 5-FU. So we conducted a phase 1 and 2 trial. We started giving, because we saw all this dysphagia relief, like patients, their swallowing got better, we never had to put feeding tubes in patients, we routinely gave induction chemotherapy first and then added chemoradiation. So this was a phase 1 trial of weekly paclitaxel, cisplatin, and radiation, 34 patients. And we had a pathologic complete response rate of about 24% because most of the patients went to surgery, and maybe a little bit of uptick in the R0 resection rate. So it was tolerable. We then took this to a phase 2 committed preoperative protocol in 41 patients, and 92% of patients had dysphagia relief with the induction chemotherapy. 5% required a feeding tube, because some surgeons still in the community, oh, you're going to get chemoradiation, they put a feeding tube in without even talking to the patient. We almost never put feeding tubes in our patients. And we had, again, about a 22% path CR rate, and 80% were R0. So at the same time, Irinotecan Platinum was the other regimen we were developing, and we were so impressed with the response and tolerance of this that we did phase 1 and 2 trials combining this with radiation. And again, I put probably every single patient on this trial myself. In conjunction with Dr. Baines, we'd see the patients together in clinic, and we'd have a unified voice in how they should be managed, and it's really a model of multidisciplinary care for patients. In the phase 1 trial, we actually showed we could give full doses of this regimen with radiation. We had no stomatitis, we had very little esophagitis, and very little diarrhea. So this was hands down better than infusional 5-FU cisplatin, and we saw a path CR rate which was comparable, phase 1 trial. So then we did a phase 2, 55 patients, mostly adenocarcinoma. Again, we gave induction chemotherapy followed by chemoradiation. R0 resection rate's about 70%, path CR rate of 16%. We also built into this trial, because there was emerging data at that time that if you get PET scans during induction chemotherapy, and your PET scan gets better during induction chemotherapy, that portends better response and better outcomes. So we built in repeat PET scans during the course of treatment. And we made an observation in this phase 2 trial that if you had a good response on your PET scan after induction chemotherapy, when you then went to chemoradiation and surgery, you had a much higher pathologic CR rate, 32%. If you were a PET non-responder, only 4%. You had a much better chance of R0 resection if you were a PET responder, 84 versus 57%, and quite striking differences in progression-free and overall survival. We then subsequently added bevacizumab to this regimen, not beneficial, but I'll talk about how we applied these data to develop a national trial to use a PET scan to direct treatment. These are data that Dr. Goodman presented yesterday. So the Dutch also did not like infusional 5-FU and high-dose cisplatin. They piloted weekly carboplatin paclitaxel and radiation in phase 2, and then they took this to a globally practice-changing phase 3 trial called the CROSS trial. It was conducted at 4 centers in the Netherlands, and they gave a very humane, very easy to administer weekly chemotherapy regimen, paclitaxel, carboplatin, and radiation, followed by surgery versus surgery alone. And I remember I showed you this statistic over and over again. If you do surgery alone or you give pre-op chemo, this is what you get with R0 resections, and they increased it to 92% with chemoradiation. And this was a positive trial. It translated into a 13% improvement in 5-year survival. A big difference for the squamous cancers, but still a significant difference for the adenocarcinomas, and acceptable rates of pathologic complete response. I used to argue with people, you have to give 5-FU cisplatin. We just can't get away from this regimen. Anything else is less effective. And I had been arguing from our phase 2 data that we have these other alternatives that are a lot less toxic. They need to be evaluated, but this was not to happen until the publication of these data, when 5-FU cisplatin was finally laid to rest. So I just want to discuss the PET scan data. Again, this is the beauty of being at a single institution, treating every patient. This is our Irinotecan platinum schema. We gave induction chemotherapy for 6 weeks, followed by chemoradiation, followed by surgery. The reason we did a PET scan is 6 weeks was so insurance would pay for it. So PET scan response had been defined by German investigators as a 35% decline in SUV. And as I said earlier, if you responded on your PET scan, every outcome was improved: R0 resection, pathologic CR, progression-free, and a trend towards overall survival. But if you looked at these 2 groups of patients, there was no discernible difference, no difference in stage. It's not like all the PET responders were N0. You couldn't discern a difference looking at the staging of these patients other than how they responded to treatment. So here we saw improvements in progression-free survival for the PET responders and a trend towards improvement in overall survival. And we talked about this. So, and here's another thing that, again, when you see every patient and you sort of see what they're going through and what they're experiencing, 4 of the patients on this trial actually progressed on induction treatment. And actually 2 of them were quite stunning, how rapid and virulent their progression were. And this was determined on PET scan or even on physical exam. So 7% of the patients progressed during the induction treatment. So we took them off the protocol. And how can you keep treating them? So we decided, because these 4 patients still had local regional disease, even though it had progressed, we switched them to paclitaxel-based chemoradiation. And 15 years later, 2 of the 4 patients remain in complete remission with a change in treatment. And I think actually one of the most stunning, and I'll show you the PET scan images, this was a 21-year-old woman who couldn't swallow her saliva. She had a massive squamous cancer, and I remember Dr. Baines saying to the patient, well, even with chemotherapy and radiation, we're not sure we're going to be able to operate on you. So she received induction chemotherapy and then became completely obstructed and developed new celiac lymph nodes on a 5-week PET scan. And I'll show you her scans when we switched her treatment. This is another patient that we treated with squamous cancer. This was a lovely lady progressed rapidly on induction chemotherapy. She developed a new hard-fixed supraclavicular lymph node, and she got Taxol-based treatment and radiation, and she lived another 10 years, and then actually had a complete remission, and then she developed a second primary. She developed a new primary. This is a patient I saw a few weeks ago in clinic that had progression on induction chemotherapy, and then when we changed his treatment, he had a microscopic T1 disease, and I actually saw him in clinic a few weeks ago. He's still doing tremendously well. So this is the 21-year-old that we started induction chemotherapy. She got so sick she couldn't swallow anything. We had to place a feeding tube. This was her PET scan after induction treatment. She had new celiac lymph nodes. The primary tumor progressed. We gave her chemoradiation, and when Dr. Baines took her to surgery, she was a pathologic CR, and she's still alive 15 years later. She's now, I guess, in her late 30s. So what we learned, I think, from these single institution observations and from published data, that if you don't respond early to chemotherapy, you're not going to gain from continuing the same chemotherapy. And we saw, at least in our few anecdotes, that we had a potential to change treatment and salvage patients that were progressing on treatment. So this led, and Dr. Karen Goodman did a phenomenal job leading this trial nationally through CALGB 80803, using PET scan to guide chemotherapy during combined chemoradiation. So we limited this to adenocarcinoma, T3, or node positive. We randomized patients to get either weekly carboplatin Paclitaxel, which is the more conventional regimen with radiation, versus FOLFOX. Then we got a PET scan 5 to 6 weeks into treatment. And if you were responding on the PET scan, if your PET scan was better, we kept you on the assigned chemotherapy. So FOLFOX responders continued FOLFOX, carbotaxel responders were continued. If you didn't reach that threshold of response, we crossed you over to the other regimen. So if you were not responding to FOLFOX, you got carbotaxel. If you were not responding to carbotaxel, you got FOLFOX. And we knew from our data that you had a 5% chance of having a path CR if you were a PET non-responder. Could we improve that by changing the treatment? So Karen has actually presented these data at 2 national meetings, and we're knowing the glacial pace of CALGB data management, hopefully we'll get the manuscripts for this. But the primary endpoint of this trial was to improve the pathologic complete response rate in the PET non-responders. This was a bad prognosis group of patients, 80% T3, and the vast majority were node positive. And this was actually a positive trial. So here is the FOLFOX arm, and here's the carbotaxel arm. We randomized over 250 patients. So if you look at this, these are the crossover patients. So these are the patients, if you got FOLFOX and it didn't work, you switched to carbotaxel, and we observed a path CR rate of 19%. So we clearly met the primary endpoint. It was better than 5%. The carbotaxel patients who crossed over to FOLFOX, we got a 17% path CR rate. And actually, the most active arm was the continuous FOLFOX arm, where we had a path CR rate approaching 40%. So we actually met the endpoint that you could potentially enhance rates of pathologic CR by changing chemotherapy. So how about survival outcomes? This trial was really not powered to show survival outcomes, but the median overall survival was quite comparable, maybe a little better to existing studies. PET responders did better than PET non-responders, but remember in this trial we crossed patients over to a different treatment. And this is the outcome by arm. So again, it's not powered to look at survival, but there is a suggestion that the FOLFOX arm that got FOLFOX with a response had the highest survival, and the lowest survival was the patients that got a carbotaxel initially and then FOLFOX salvage. So I'm going to shift gears a little bit and talk just briefly about adjuvant therapy in gastric cancer, because we've also been an active voice in guideline development for gastric cancer as well. For many years in the United States, we were obligated to give radiation and chemotherapy after gastrectomy. This was based on a positive adjuvant trial that Jack McDonald published back in 2001. The problem with mandating radiation after surgery is patients had very poor quality surgery. Was the radiation just making up for poor quality surgery? Then the MAGIC trial we talked about earlier, this is perioperative chemotherapy without radiation. This was a positive trial. I'll just mention briefly now that the FLOT regimen has displaced ECF as the perioperative standard. But really, sort of my contribution to the dialogue is the Asian approach. In Asia, it's typical to do they don't do preoperative chemotherapy in Asia. They do upfront gastrectomy, and then they give adjuvant chemotherapy. And there were 2 positive trials that treated 2,000 patients. 2,000 patients, they all had the best quality surgery, D2 resections, and you had 2 positive trials for adjuvant chemotherapy. Oral 5-FU for a year, a 10% improvement in survival, and then capecitabine oxaliplatin for 6 months. My American colleagues would not accept this. They said, this is Japan, this is Korea, we can't believe these data, S1 is a magic pill. Capecitabine oxaliplatin is not a magic pill. That's a Western chemotherapy. And what really convinced me to promote this is I used to go to NCCN meetings in China because the Chinese use the NCCN guidelines to guide their care in China. And we would sit around the table discussing treatment guidelines, and they would say to us, how can you not discuss adjuvant chemotherapy? This is what we do in Asia. This is 80–90% of the world's gastric cancer, and you're not acknowledging it. So after a few of these meetings, I kind of realized that they had a point, and we added adjuvant chemotherapy to the NCCN guidelines, which I'll show in a minute. In terms of perioperative chemotherapy, the FLOT regimen has now displaced ECF. It's a better regimen. This is the FOLFOX plus docetaxel. This was a randomized trial that Salah Albatron conducted in Germany. And the bottom line is that both progression-free survival and overall survival were improved for FLOT versus ECF. So ECF has really now been relegated to the dustbin, both in metastatic disease and as a perioperative treatment. And all the other endpoints were improved with FLOT, better resection rates and better response. So I just want to mention again the adjuvant therapy, chemotherapy alone in Asia. This is a 1,000-patient trial where you got survival benefits for adjuvant chemotherapy as long as you do good surgery. And this is the Korean study. I mean, one of my colleagues actually wrote an editorial about the S1 and said, New York is not Nagoya. We can't believe these data. We just can't believe this. So this is 6 months of capecitabine oxaliplatin. That's a Western regimen, a clearly positive trial. So if you do upfront surgery and you do a good surgery, you give patients adjuvant chemotherapy. You don't deny them that. So now the NCCN guidelines, these are patients with gastric cancer that have had no previous treatment. If they have an R0 resection and they get a D2 lymphadenectomy, they get adjuvant chemotherapy. I spilled blood to get this into the guidelines. So the role of radiation therapy, and where I think radiation therapy is needed for esophagus and G-junction cancers, for gastric cancer, it really is dependent on the quality of the surgery. So if you do less than a D1 resection, you probably need radiation. If you do good surgery, you can get perioperative chemotherapy or adjuvant chemotherapy alone. So just in the last few minutes, I'm going to talk about the advent of targeted agents and a little bit about immunotherapy. And we now, Yelena Janjigian, my colleague, is becoming an international leader in the development of immunotherapy and targeted agents, and certainly a much-deserved appointment as our service chief, and we're very excited about that. And I just want to tip my hat to Yelena. So targeted therapies, we saw the data for chemotherapy. It has limited benefit, and the hope is that we can identify more specific molecular targeted therapies in cancers. But there's a caveat. I wish everything were CML. We really need to develop biomarkers in gastroesophageal cancer. They need to be validated and developed. Although genomics may identify candidate pathways, it's highly unlikely, and we've learned this over and over in recent randomized trials, that it is unlikely that one pathway or even a series of biomarkers or pathways will advance the success of therapy. we really need to appreciate the networks and patterns of multiple biomarkers, and we're on the case, but we're not there yet. So we were big contributors to the Genomic Atlas. Fresh frozen tumor biopsies were sent to Adam Bass's lab, and this was an effort to characterize 300 fresh frozen gastric and GE junction cancers, looking at 6 molecular platforms. This is one of their early publications. It actually turns out if you compare esophagogastric to colon cancer, this is colon cancer in the blue, you can see that esophagogastric cancers, they're genomically much more complex. A lot more copy number events, a lot more gene amplifications. And here's some hopeful news. 40% have these pathways that are amplified. So these are targetable, right? EGFR, HER2, MET, but trials didn't work. So EGFR is a failure, MET is a failure. We've got some mixed results with HER2, and I'll show you some interesting data that Yelena has generated showing potential resistance mechanisms for HER2-targeted therapies. So 4 genomic subsets of esophagogastric cancer have emerged. The most common is the genomically unstable tumors. These are the ones that have the receptor-associated tyrosine kinase amplification. These are the HER2 patients. They usually all have p53 mutations. There is a subset of MSI-high gastric cancers. Unfortunately, it's quite rare, but these are tumors that have dramatic responses to immune checkpoint inhibitors. Genomically stable tumors are the diffuse gastric cancers with not a lot to offer. And then the EBV tumors may also be candidates for immune checkpoint inhibitors because of overexpression of PD-L1 and PD-L2. So we were hopeful that HER2 was going to be a gold mine in esophagogastric cancer, but unfortunately only trastuzumab has resulted in positive results. The TOGA trial did show an improvement in survival adding trastuzumab to chemotherapy in HER2-positive patients, but lapatinib, the tyrosine kinase inhibitor, failed, and even a bigger disappointment was pertuzumab, dual-targeted HER2 therapy did not improve outcome compared to trastuzumab alone. So Yelena and all of our colleagues recently published some very elegant work in combination with the genomics group, publishing data using impact analysis on our patients treated with trastuzumab. We had tissue samples also after trastuzumab, so you could potentially identify resistance mechanisms, and she had 23 matched pre- and post pairs. So why do patients fail trastuzumab? Well, at progression, 16% actually lost their HER2 expression, so that's a plausible explanation. But they also developed amplification and mutation in crosstalk or resistance pathways, EGFR, HER4, IGF-1R, MET, an increase in amplification of PI3 kinase, which again, these are also downstream pathways from these targets. So very plausible explanations for why patients develop HER2 resistance. And I always like to show this picture because this is the pre and this is the post trastuzumab. You can see the acquisition of all these mutations and abnormalities. So these data are hypothesis generating. Can we design trials to potentially overcome drug resistance? Trastuzumab also, this is another trial that we helped design and lead nationally, is adding trastuzumab to chemoradiation in HER2-positive esophagogastric cancers. We should be getting a readout of this preoperative neoadjuvant trial within the next year. So I'm just going to end the talk just to mention briefly immunotherapy. Everybody shows this slide when they give an immunotherapy talk. This is the mutational spectrum of solid tumors, and you can see that melanoma tops the list. But esophagus and gastric cancers, they're up there. They have a pretty high mutational burden, so these are reasonable candidate tumors to consider the study of immunotherapy. I'm just going to mention the three key recent trials. We're not going to go into all the data. 2 positive trials for immune checkpoint inhibitors in esophagogastric cancer. Keynote 59, this was a large expansion cohort of pembrolizumab in refractory gastric cancer, and it led to regulatory approval for pembrolizumab in PD-L1 positive patients. There was a response rate of about 15%. Some of these responses are durable. Then the Asian study was nivolumab versus best supportive care in refractory gastric cancer. This also showed a survival benefit, and nivolumab is now approved in Japan for chemotherapy refractory gastric cancer. But with the good news comes the bad news. Is pembrolizumab better than chemotherapy? Keynote 61 was a head-to-head comparison of second-line weekly Paclitaxel versus pembrolizumab, and there was no difference in overall survival. So I just want to mention the ongoing pivotal trials, and this is, again, a hats off to Yelena Janjigian, who's the global PI for this first-line trial of FOLFOX versus FOLFOX nivolumab in untreated metastatic gastric cancer. There's also a pembrolizumab trial alone versus chemotherapy versus the combination. And then there's an ongoing trial looking at PD-L1 maintenance therapy in patients. So I took you through my 30-year experience at Memorial. You can see the strength of being at a single institution, that you can build upon trials that you do. When you treat every patient, you get insights that you just can't get anywhere else. And again, I said this last night, it's a tremendous privilege to have been here. So I think we helped establish Paclitaxel and Irinotecan-based therapies in advanced disease. We also were helpful in adoption of colorectal cancer chemotherapy schedules, the use of taxane platinum with chemoradiation. I think we were instrumental in clarifying the role of radiation in the adjuvant treatment of gastric cancer, and we helped build a global consensus that there are several appropriate approaches depending on the nature of the surgery that you do. We also, I think, are identifying PET scan as a potential useful biomarker of response to preoperative treatment, and we're at the forefront of moving targeted agents and immune checkpoint inhibitors forward. And thank you very much. Yeah, I think quality of life absolutely has to be built in, particularly for some potentially very toxic treatments. I think for late-line drugs, it's overall survival because they really don't have other options. And I think that you're not going to get clear signals from PFS. Response rate is kind of a weak endpoint because some of these novel agents are stabilizing and you get delayed responses. So I think for late-line agents, and we learned this from breast cancer, I mean, you don't see survival benefits for upfront new drugs in breast cancer because they have 20 other options. So a signal of benefit would be diluted out. So I think for late-line drug development, I think overall survival is the endpoint and quality of life is critical. Response rate is a bit of a soft endpoint that we typically have used that as a signal to pursue a drug further. But if you have somebody respond to a drug and it lasts 2 weeks, it's not, I once reviewed a paper for JCO. They were so excited that they screened 400 patients and they found 4 patients that had some mutation, and they gave them a targeted drug and they saw 2 responses that lasted 2 weeks. And I said, you can't say this is an interesting signal here. But I think composite of endpoints, I think earlier drug development, probably PFS is not an unreasonable endpoint if patients have other treatments to go on to. Quality of life absolutely has to play a role. I think I showed you the DCF, does the punishment fit the crime? Clearly the punishment doesn't fit the crime, and there are some treatments that are just not worth giving to most patients. Yes?
Patient has a locally advanced T3N1 tumor. The tumor is at G-junction cardia. Tumor is HER2 positive, and the patient is getting FOLFOX and Herceptin. As you described in the study, after 2 weeks, 3 weeks, the reduction in avidity 70%.
Yeah.
Followed the same regimen up to 8 cycles. Again, PET scan, no difference in...
No further improvement.
No further benefit. How to explain that, and would you still, after 8 cycles, go to different chemotherapy?
Well, no, I mean, this patient responded, and if they're operable, typically for the G-junction tumors, I favor adding radiation. I'm worried about getting a negative margin. So I think this is a patient, I mean, this is T3N1, it's localized, these are curable. So you don't want to give chemotherapy forever. And the question is if you think the response is enough that you can send them right to surgery, or you should give them 5-FU oxaliplatin radiation. We don't know whether trastuzumab should be given as part of neoadjuvant treatment. We have to wait for the RTOG 1010 data to see whether adding trastuzumab improves outcome. But this is a patient, if they've responded, and that response may plateau. That doesn't mean you should change the treatment. But I'm not sure why you're not sending the patient to surgery or adding radiation if it's a locally advanced tumor. Now we would give FLOT. I mean, if you're going to give preoperative chemotherapy, I would use the FLOT regimen if you're going to give chemotherapy alone. If you're going to give chemoradiation, we like our PET scan data. I'm not sure it's ready for prime time. I mean, carbotaxel radiation followed by surgery would be the other standard.
The second question is, patient is HER2 positive after 8 cycles of chemo and Herceptin, still HER2 positive, about 80 to 90%, not more than 10, more than 30%, but 80 to 90%. MSK repeated, MSK impact repeated. HER2 is still there.
Okay.
Amplification, and no additional co-mutations, but no further response on Herceptin.
Yeah, well, chemotherapy alone does not induce complete responses very often. So it's not like they have to continue to respond. To me, the issue, if they get to surgery, do you give adjuvant Herceptin? We have no idea whether that improves outcome. We're going to get data from RTOG 1010. We typically don't give trastuzumab with HER2-positive patients in the neoadjuvant setting until we have data. There is a potential for cardiac toxicity with radiation, and so wait for the data.